Good afternoon out there, everyone. Dr. Tony Brown here, coming to you with another edition of Increasing Your Revenues. So, today we are going to chat about iron deficiency. Um, we are still planning on having Dr. Kanodia, that is, to come aboard and answer questions from everyone. However, what he requested is that he get another 2 weeks to be able to answer all the questions, and he's going to make a recording and send it in to us. So, but no problem. We are going to just keep pushing forward with what we are already doing. That is going over specific pathologies and, excuse me, talking about how to approach those. So last week we did the methyl tetrahydrofolate reductase gene deficiency. I'm sorry, methylene tetrahydrofolate reductase gene deficiency, and how that presented in your patients with increased homocysteine, what that patient looks like when they walk in the door, and most relevant to this webinar, which labs to order. So we are going to do the same thing today with iron deficiency. Let's talk about iron deficiency, and we're basically going to use these few slides to build up to which labs should you order if you suspect iron deficiency. Okay, so we've got the introduction here that more than 25% of this earth is anemic, right? And about half of the burden of that anemia is from iron deficiency. Okay, let's put that in perspective. A quarter of the earth is anemic. Now, if you take that anemia, half of it will be caused by iron deficiency, the other half by other things, B12, B9, folate, this kind of stuff. So playing odds, there's an awful lot of people out there who are iron deficient. Okay, the prevention and treatment of iron deficiency is a major public health goal, especially in women, children, and low-income countries. So we're going to cover actually four different categories. What that older adult looks like, the chronic disease patient, the inflammatory bowel, and then just the general iron deficient patient who might be walking in the door. Now, let's talk about whether or not to do anything at all, right? That's going to be the initial concern for those of you out here. Even after we identify the signs and the symptoms, your first thought is going to be, should I let this go? Should I watch and wait? Should I actually intervene? So let me say this, regardless of the presence of symptoms, all patients with iron deficiency anemia, as verified by your CBC, etc., all patients with iron deficiency anemia, and most patients who have iron deficiency, even without anemia, should be treated. If you have iron deficiency anemia, it should be treated. The rationale is that there's a risk for further organ damage and ischemia if you let it go. Now, of course, the exception is when you might already be using iron depletion as a therapy, right, for porphyria or polycythemia, something like that. Now, some of the patients are going to have iron deficiency, but they're not going to have any symptoms. What are those symptoms? Weakness, headache, tolerance, fatigue, irritability, depression. I know you're saying, well, those are really generalized and really ambiguous and really nonspecific. Exactly. Yes, but you've got to start somewhere. Okay. So one of the thoughts is that you could put together a general profile that fits your particular patients, right? I don't know if you have a vegetarian population or if you have a a meat-eating population, or right? There's different panels that you could put together to reflect that. Neurodevelopmental delay, that'll be obvious in the kids that are walking into your office. Wanting to eat dirt or ice, reddish urine after eating beets, right? Reddish urine after eating beets. Porphyria, right? Now that's an interesting one to me because porphyria is basically a buildup of protoporphyrin, and depending on what's broken, you can actually kind of localize what's going on with your patients. Some of them might walk in with a sun-sensitive rash. Some of them might come in with neuropsychiatric conditions. Uh, each of them tell you exactly where the enzyme is broken, and we can talk about that later if you want to talk offline about it. But it's the difference in knowing the porphobilinogen deaminase and whether or not you've lost an enzyme downstream or upstream of it. And I can give you an idea of exactly where to target in your tests. So back to this idea about, and I'm trying to give you a nice and warm and fuzzy about ordering iron labs at all. All right. So, of course, the therapy for iron is individualized. It's according to that patient. Now, here, take this sentence. We replace iron stores in most patients who have iron deficiency without anemia with the rationale that this treatment is likely to improve symptoms, and failure to treat is likely to result in anemia. Okay, so you're just playing odds. Do something, they're more likely to get better. Do nothing, they're more likely to get worse. Okay. Um, Now, of course, if they do get worse, you can refer that patient to a hematologist and then find out with further testing what might actually be going on. Everything I'm saying here is supported by trials and observation. It's a nice, long, boring list of references and bibliography at the end of the slides. Um, so you've got a source of iron deficiencies, right? You can have, if well, you're most concerned if the patient is a non-menstruating woman or a man, right? If there's some iron deficiency there, you really want to be concerned. Dietary deficiencies, kids that are being um, solely breastfed on milk. Meats, you get iron. Vegetables, you get iron. Grains, they've been supplemented in America with iron. There's some impaired absorption problems that you might have, inflammatory bowel diseases, some kind of bypass surgery. Pregnancy, right? You're going to use more of your iron just growing another human being. So these are some examples, right? Bleeding. Uh, when a woman is menstruating, keep in mind, normal menstruation is not going to lead to iron deficiency. So I can't tell you how many times I've stood in a clinic and a woman comes back with a low hemoglobin and the doc asks, is she menstruating? Ah, there you go. No, normal menstruation won't lead to iron deficiency. Okay. Let's see, the Helicobacter pylori infection, gastritis, celiac disease. All of these might interfere with your patient's ability to absorb iron. Some renal pulmonary syndromes, right? We're talking about things like Goodpasture's syndrome, also post-streptococcal glomerulonephritis, right? That patient that comes in with an upper respiratory infection that they had 2 or 3 weeks ago, and now all of a sudden they've got some red blood cells in their urine. Right? These are key signs, right? Athletes can lose it by having an increase in inflammatory cytokines. We'll talk about that in a moment. Um, so any patients that you have in these populations, I basically broke these down into populations so that you can apply the population that most fits to your particular um, um, demographic. If you are planning on marketing to um, personal trainers, okay, Personal trainers are going to have lots of athletes. Athletes have lots of inflammatory cytokines. There's a reason to order an iron profile, right? Okay, so now let's talk specifically about which labs to check. So, of course, if I'm checking for iron, one of the things I can do is check my iron labs. Okay, so you can check iron levels. You can check transferrin. As a matter of fact, I'm going to switch over here to bring up a VirtualClinic sample report. Okay, so here you've got a sample report, right? And you know you can start up. I think you guys have seen this from the very top, where you have all the biomarkers, and then it does a kind of analysis where it takes all of the things that are abnormal, sticks them up way at the top so you can see those first. Okay, so that's where these are, right? Everything that's low, everything that's high. Of course, low doesn't mean good and high doesn't mean good. It depends on what it is that we're talking about. So I am going to go past that and then look at these particular graphs, specifically the one that has to do with red blood cell health. Now, so red blood cell health, let's look at hematocrit. What does that even mean, hematocrit? So when we talk about hematocrit, guys, so first of all of this is something you can order in a ready-made basic profile that we have. Also, you can put it together with some kind of specialized profile that you might want to put together for your patients. So hematocrit, it literally means red blood cell judge, right? In the Greek, red blood cell judge. Judges had the power to decide if you were guilty and then separate you from the population for punishment. Hematocrit means separating the red blood cell from the rest of everything else floating around in your plasma. Okay, so normal you run around 40% for males. So this male is low at 34. And literally, we're saying percentage by volume of all of your blood. And if we poured it all out in a big test tube, 40% of that test tube should just be red blood cells. Hemoglobin, right? So hemoglobin, if you think about hemoglobin, if you take one red blood cell and you put it on a scale, 94% of the weight of that red blood cell is going to be hemoglobin, because there's 300 million molecules in one red blood cell. So 94% of the weight is hemoglobin. But if you measure it by volume, it's only about 30% of it. But because of those two numbers, it gives you a really good idea of what's going on with your red blood cell health. Okay, this patient looks to be low on hemoglobin. The mean corpuscular volume, the mean corpuscular hemoglobin, the mean corpuscular hemoglobin concentration. Let's look at that. So that is when you look at the concentration, it's really a measure of how much liquid is inside the red blood cell, because sometimes your patient might have, beta thalassemia, which is going to drive it up, right? Because some of the liquid's going to leak out. So you can use that for differential diagnoses. Mean corpuscular volume. Now, this is a real good one, because this means that if you take all the volumes of the red blood cells and then average them, are they generally going to be larger or smaller? So what's it going to tell you about your patient when you have an increased mean corpuscular volume? Well, too big is macrocytic, right? Big cell, macrocytic. So you say to yourself, what are the things that cause too big red blood cells? B12 deficiency, B9 deficiency, right? Both of those. So that would give you a key as to what to start looking for with regard to that anemic patient. What if it's too small, right? Anywhere between 80 and 100 femtoliters. I don't think those numbers are on here. I'm weird and I have them memorized. So anything between 80 and 100 femtoliters is normal. Anything over 100 is too large. Anything below 80 is too small. We've just talked about some differential diagnoses for too large. For too small, that goes directly to what we're talking about here, right? Microcytic anemia is what you're going to have with iron deficiency. Iron deficiency. Okay, and red blood cell distribution width. So, right, your patient could have a presence of two conditions at the same time, right? For instance, they might have iron deficiency and B12 deficiency. What did I just say? They might have microcytic anemia and macrocytic anemia. And then when you look at this RDW, it's all balanced out because some of them are too small, some of them are too large, and then they all actually balance out on the RDW. Okay, so don't use your RDW in your labs as a drop dead way of trying to figure out whether or not the patient is iron anemic or iron deficient. Okay, all right. I'm going to go back to the original slide set we were on here and continue talking about labs that you can order and differential diagnoses of those labs. Okay, so we've talked about serum iron, right? You could just plain old check the iron levels. Transferrin. So transferrin is a protein that you can order in the VirtualClinic laboratory where it will give you some idea of how much iron is in the plasma being carried in the blood by a protein. Okay, so transferrin. And what typically happens, right, is that you can have iron in the plasma and iron in storage. You can store it in a couple of places, liver. You can also store it in the bone marrow. So what you want to do is to compare these. And what I mean is take a look at the next one, the ferritin. Ferritin. So if you have a low iron level and a low ferritin, now ferritin is the protein that stores the iron in the bone marrow. So if I'm low in my serum, normally where does your patient get their iron from if it's low in the serum? It would go to the ferritin in the bone marrow. But what if you're low in the serum and they're low in the bone marrow? Okay, that is pretty much diagnostic of iron deficiency. Low serum, low bone marrow, and then elevated total iron binding capacity. What that means is if I have a protein that's able to bind 4 molecules of iron, if I am fully saturated with all the iron I need, transferrin, for instance, if it's carrying everything that it needs, it's going to have all 4 spaces filled, and it has a 0 total iron binding capacity. Right. So the lower the capacity, the more iron must be floating around. But what if out of those 4 seats, I only have 1 of them filled? Right. Then I've got a total iron binding capacity of 3 out of 4, 75%. That's bad. That means that the proteins responsible for carrying the iron in my plasma are pretty empty. There's a lot of binding capacity. So when you look at your patients, iron levels, and they're low, and the ferritin levels are also low from the storage, and the proteins that are transferring the iron in the blood are also high TIBC, that is diagnostic of iron deficiency. Now, you don't want to just use one, right? Don't just order a ferritin and think that that's going to do the job. True. In most cases, if you have a low ferritin, that is to say, low storage inside the bone marrow, in most cases, when your storage is low it's pretty much diagnostic that you must be low. Because why would your body be draining the storage if it wasn't low in the plasma in the first place? Now, that is true in most cases. However, there is a condition called anemia of chronic disease. Anemia of chronic disease, where the ferritin levels, your patient's going to be sick, but your ferritin levels are going to be normal or maybe even high. Normal or maybe even high. Uh, and so, what's an example is infection. Okay. Whenever the body is infected, it evolutionarily has learned to pretend that that infection is from bacteria. May or may not be, but the body reacts as if every infection is bacteria. So the body knows that bacteria love to munch on iron. So it does what? It takes the iron and it hides it away in the bone marrow. So it takes that iron, hides it away in the bone marrow, and the problem, I mean, it's a good thing that it's hiding it away from the bacteria. That's what it sees. Bad thing is that it's also hiding the iron away from the body. So yes, the bacteria starve, but the body becomes anemic with microcytic anemia. Okay. Now, so that's called anemia of chronic disease. What chronic disease? A whole bunch of them, right? Hepatitis, anything with inflammation, anything with infection, all of those means that you're going to have a whole bunch of iron stored in that bone marrow. So you're going to be looking for a low ferritin storage. And if you just automatically say, my ferritin's okay, there must not be any anemia, then you can miss this. Okay. We've already talked about total iron binding capacity. And I'll end it today with talking about the hemoglobins, right? So you do want to check the hemoglobins. There's a lot of different ones, right? Here's the normal one, hemoglobin A. If that's low, that means, of course, there's probably been some kind of bleeding going on. Hemoglobin A1C, you check that in relationship to diabetes. And what does that have to do with anemia? Is that one of the problems with diabetes is end organ damage of the kidney. The kidney is responsible for making erythropoietin, which is it's the hormone that triggers your bone marrow to make red blood cells. So you could have a diabetic patient with end organ kidney damage who's going to be anemic secondary to diabetes. Check the A2 levels also, hemoglobin A2, because right, those levels are going to be perturbed with beta thalassemia. Specifically, they will be increased with beta thalassemia. Okay, so those are some levels to check. There are already some pre-made basic panels in CBC labs that are on your portal for VirtualClinic. So if you need any advice in using them, just reach out to the support number, also to Ms. Jennifer Litzter. I see you out there, Jennifer. Thanks for being here. And we should be able to give you some guidance in how to use them. If you need some diagnostic help, just give me a ring, Tony Brown. I do not mind at all chatting with you. We can get on the phone for 15, 30 minutes and talk about any patients that you have, and I'll try to give you some guidance as to how to look at their labs. All right, guys, thanks so much for joining me again today. So we will see you next week at same bat time, same bat channel. Have a great week. Bye-bye.